Welcome, everybody. I am Steve Gurney, and I am the voice from behind the curtain tonight and helping with this event. So when you hear my voice, you know that I am the guy from behind the curtain. A couple of little housekeeping things. We want to make this interactive discussion, and so you can interact with the other attendees of this discussion by using chat. And if you want people to see what you're writing, you can use that little drop down that says everyone. But and you can also put your questions in chat as well. But probably the most effective place to put questions is use that little Q&A box that's at the bottom of your screen. And that's a great way to make sure that our panel members get your question and that we put it in queue and get to answer it. But without further ado, I am going to duck behind the curtain here and turn the event over to your host, Michael Smith.
Thank you, Steve, for your assistance, and thank you for the work from Positive Aging. Good evening, everyone, and welcome to the National Capital Area chapter of the Alzheimer's Association's Community Forum. This evening's forum is meant to provide a better understanding of the experiences of people living with dementia, their challenges, their needs, resources in diverse communities such as the Asian, LGBTQ, Hispanic, Latino, and African American communities. We hope to have a high level and frank conversation this evening with our four experts. As Steve mentioned, I'm a volunteer with the Alzheimer's Association. I'm both a community educator and a support group facilitator with the chapter. And I come from a diverse community and was a caregiver to my late wife, who was diagnosed at the age of 54 with early onset dementia, and who unfortunately passed away at the age of 62 in 2017 from complications of Alzheimer's. It's important to point out that while we're discussing the four distinct communities, the Asian, the African American, Latino, Hispanic, and LGBTQ communities, there are points of intersectionality, as each individual with dementia or Alzheimer's and their caregivers and partners represent the tapestry of diversity when it comes to race, culture, sexual orientation, gender identity, and expression. I quickly want to highlight something from the Alzheimer's Association's 2021 special report, Race, Ethnicity, and Alzheimer's in America: Stigma, Cultural Differences, Awareness and Understanding, and the ability to obtain a diagnosis, manage the disease, and access care and support services for dementia vary widely depending on race, ethnicity, geography, and socioeconomic status. These disparities reach beyond clinical care to include uneven representation of Black, Hispanic, and Asian Americans, and I say as well, LGBTQ members in clinical trials. The report also mentioned the impact of the pandemic on these populations. In 2020, the COVID-19 pandemic and social justice movements sparked new conversations about the pandemic and the longstanding health and healthcare disparities faced by non-white racial ethnic populations, especially when it comes to access, discrimination, and trust in the healthcare systems. So let me now introduce our panel members for this evening. In introducing each of them, I hope to engage each of them in about a 15-minute or so conversation to learn more about why they do, what their professional backgrounds are, have them share some of their slides and information, and the resources that they provide. And also, we're wishing to, after the presentation of our four panel members, to open the panel discussion up for you all to raise questions to each of the panel members. So now let me introduce our panel members for this evening. First, we have Dr. Cecilia Hahn. Dr. Hahn is a board-certified clinical neuropsychologist specializing in serving populations with acquired brain injuries and neurodegenerative disorders. Dr. Hahn, like me, is also a volunteer community educator with the Alzheimer's Association's National Capital Area. And Dr. Hahn has done a tremendous job as a volunteer here in the Washington area. Next, we have Dr. Amina Johnson. Dr. Johnson is the Montgomery County LGBTQ community liaison. Dr. Johnson supports and advocates for the LGBTQ community in Montgomery County, Maryland. Next, we have Dr. Andre Eduardo Salazar, who is a medical director at 8 communities in the state of Maryland. Dr. Salazar is a geriatrician medicine specialist with over 35 years of experience in the medical field. Finally, we have the wonderful Dr. Flavia Walton. Dr. Walton is coordinator of Dementia Friends of Maryland and the lead for South County Dementia Friendly America in Prince George's County, Maryland. So let's first engage Dr. Hahn in conversation. Good evening, Dr. Hahn. Glad you are able to join us. So Dr. Hahn, the first question for you, can you share more about what a neuropsychologist is and what you interested in the field of dementia and Alzheimer's?
Absolutely. Neuropsychology is a study of the brain and behavior. I'm always fascinated about human mind and their behaviors. So what got me interested in that's what got me interested into psychology. And as I study in this field, I realized the fascinating aspect of our brain and how it is involved with our behaviors. When I'm involved in learning about memory and learning about other cognitive abilities, that got me into more of the degenerative conditions like Alzheimer's disease. So my area of focus is working with individuals clinically who had neurodegenerative conditions or any kind of acquired brain injuries. And I was also at the same time bilingual, and I was hoping to use my language skills, being able to help bridge the gap of individuals who are in the minority groups and not really having the access to the medical field or the medical health care. And so I think I'll be able to help with that aspect as well.
Thank you, Dr. Hahn. And you raise a critical issue, as you mentioned, that you help with bilingual issues, that often happens in communities of color, that there are not enough individuals who can help translate from various forms of languages, Spanish, Cantonese, Mandarin, what have you. Now, I want to pose some questions, and let's talk about the prevalence, if you want to pull that slide up, Dr. Hahn.
Absolutely. Let me share my screen so people can see what I have gathered here. Let me do the full screen mode. Here it is. So my session is going to focus more on Asian Americans. I'm Asian, I'm Chinese American myself. So I worked more closely with Asians in particular. So as part of today's conversation, we're going to, for me, I'm going to focus more on Asians.
Okay, thank you.
In terms of prevalence, I pulled some data from Alzheimer's Association, actually from this year. So as of right now, the data suggests that there is 6.7 million Americans over age 65 are actually living with Alzheimer's disease, which is about 1 in 9, about 10% of individuals having this disease, which is quite a lot. It has significantly increased from years before. As far as for Asians, as we all know, that there is not adequate data to support to the terms of prevalence, but we all know that it's underrepresented. But even with that being the case, the study years ago suggested it's at least equivalent. So it's about at least the same. In particular, there is a study conducted in China, and that's over 10,000 individuals over the age of 65, and they found almost 21% met the criteria for mild cognitive impairment, which is a precursor for Alzheimer's disease. And then 5% met criteria for dementia in general. So that's the overall prevalence, which is quite a lot. And that's why we need to raise the awareness in the community.
Okay. And what about assessment tools? I mean, how do we get at determining whether somebody has dementia or Alzheimer's?
That's a great point. So here I made a list of the typical assessment tools that people may have heard or have gone through when they go to their doctors. And typically the doctor will start off with a very brief talk screen. You might have heard of it, the MoCA or MMSE, and then they combine that with a neuroimaging, such as a CT scan or MRI. Those are fairly typical. Not until someone is pretty confirmed of having the symptoms pretty consistent with Alzheimer's, it is not very common to use PET scan or SPECT. But those are the kind of tools that gives us more information about your amyloid accumulation in your brain. So usually these are used for research purposes, not so much clinically, but in some cases, people still do get a PET scan. So EEG or polysomnography, those are tools to help us differentiate other kind of changes in the brain. For example, seizure activities or sleep disorders, that helps us to tease apart the difference between Alzheimer's disease and other kind of conditions. They would also look at your lab to look at if there are any metabolic changes or any imbalances in your system. Lumbar puncture is used when there is suspected infectious condition going on, which is not typically used because it's more invasive. And then, of course, there are specialty care, which is sometimes the primary care will refer you to, including a neurology, including to geriatrician, and then psychiatry. And myself, I focus more on cognitive assessment, looking at your memory, attention, processing speed, etc., as well as your mood, your emotion, to tease apart which is more of a cognitive aspect versus more of a psychological aspect. So these are the typical assessment tools. And I wanted to say that the imaging in the labs are not definitive as of now. So even though sometimes people see a negative imaging, doesn't mean that they don't have the disease, or sometimes indicates atrophy, doesn't necessarily mean that you do have a disease. So there are ongoing effort in research in trying to identify more biomarkers to help assist with the differential diagnosis.
Can you quickly speak to what specialists should one start with? I know oftentimes, again, in community of color, particularly even in the Asian community, we often go to our primary care physicians or our family practitioners. Do they know about these MRIs and PET scans and EEGs, or should, you mention specialists like neurologists or geriatricians, should an individual family member start there?
I think it's a good question to pose to a primary care doctor. Sometimes, especially for minorities, doctors may not have that cultural sensitivity in recognizing the changes, but if you describe the changes that you notice and how does it not match to your cultural background, your personal background, and that might raise the question about, is this typical aging or this is something abnormal, and we need to get a specialized provider to look at that aspect. I think it's helpful for us to know a little bit. You don't have to know too much, but at least you can pose that question to your primary care.
Okay. But what are some of the barriers? I mean, what's some of the reluctance in the Asian community to go to the doctors or to get an assessment or diagnosis? Can you speak to some of that?
Absolutely. So in terms of the barriers, I could think of quite a few here already. The very first one is the lack of accessibility to healthcare. Sometimes it is just not having enough resources in the region. And other times it is not enough providers who are culturally competent, who recognize the nuances of each individuals. That can also include, for example, application to health insurance applicable to their health care, etc. So in general, there is a limited accessibility to care, and we as a society need to take a closer look at that. And the other main aspect, I think it's very important to start to understand for the society is the misconception or lack of awareness or inadequate awareness and understanding about cognitive impairment and dementia. In layman's term, that means stigma and discrimination. Sometimes people just feel ashamed when they notice changes and they don't want other people to know. And this is very common in Asian culture as well, because they keep things to themselves, and rather than sharing with the doctors, they wanted to minimize that. And I quite often see people coming into my office and trying to tell me that they can do everything still by themselves because they don't want to lose the freedom, they don't want to lose their personal abilities. But there are sometimes family members start to notice the difference. But usually when it comes to Asian American, it is towards the mid to later stage. So I think it's important to raise the awareness so that people can get care ahead of time, earlier in the stage, and try to address the symptoms right away rather than wait till too late.
Okay.
So that is a very important aspect to keep in mind. As far as for assessment wise, there are a wide variety in the Asian populations. For example, language, it's a huge barrier if someone does not have English proficiency. This is because a lot of the cognitive tests that were developed are mainly for English-speaking individuals. So for example, Chinese patients coming to my office, I have to select certain tests, but not all of them, because they're not available for their language. So that is a huge barrier. Another barrier is the heterogeneity of Asian populations. I did a quick search on Google, and it suggests that there are 51 countries and over 2,300 languages just in Asia. So that's a very wide range. And for us to understand each type, each country, it takes a long time. But I think a competent provider will be patient enough in trying to understand each person's background. But it's important to recognize the heterogeneity of the Asian group. Education levels and quality, I found that to be a pretty big confounding aspect, because in the US, we count the person's education level by looking at how many years of schooling and trying to get a rough estimate. For example, high school equals 12 years. That helps understand where this person's abilities level is estimated to be at. But when it comes to Asian populations, this range widely. And there are people, because of cultural reasons or country reasons, that they don't have the education that they are supposed to get when they were younger. But it doesn't necessarily mean that they have no ability to understand things. Their IQ, and doesn't necessarily mean that it's substantially low. So we need to understand the differences in their education background, the quality, the levels, and not just the number of years, because getting education at Ivy League schools is very different than getting education from an online program. So we have to tease apart those nuances, especially for Asian populations. Okay. In terms of cognitive assessment, which is something that I do, I found that there is a lack of culturally sensitive measures, not just for Chinese-speaking individuals, including other languages as well. In general, it's very hard to find the type of measures that match well to their education and individual cultural differences. And getting the normative data, it's pretty challenging. But as a field in neuropsychology, we're trying to get as much data as possible and trying to accommodate more culturally diverse population as we can. Sometimes there are inappropriate translation of tests, and we don't encourage people to do that because direct translation may not necessarily capture all the cultural nuances. So people could go through, a Google search and translate the test, but that is not recommended. From my perspective as well, because I'm also a psychologist at the same time, I need to pay attention to some psychiatric and, the physical aspects of their symptoms, which can mimic memory problems, mimic attention, cognitive issues. So you have to understand sometimes there are overlap and sometimes they are mimicking those symptoms. So we have to keep all these in mind as we're assessing someone from a minority group.
Okay. Can you quickly give us some sense of recommendations that you would offer in terms of how do we deal with issues around cultural competency? What can happen within the Asian community? What can happen in the community at large? And even in the healthcare community?
Yes, I think as far as for recommendations, it is very important for providers, which is like me, to pay attention to these differences. I work with a diverse group of patients, and sometimes I may or may not fully understand their background, but you need to have the sensitivity to the differences in recognizing. Sometimes it may not be that they don't want to share freely with you. It's because their culture, they feel like it's inappropriate to share that. So you have to recognize it and be transparent about it. and sometimes pointing it out in a constructive manner so they can describe their symptoms in a more comfortable way to share with you about what they truly experience. And that's very important. And sometimes providers, if they don't have that sensitivity to it, they might oversee some significant changes or important signs. So that's important to enhance their sensitivity as providers to those cultural differences. Another recommendation, I think, is to do as much community education as I can possibly, which is what Michael and I have been doing as a volunteer, and providing education to the general public, the understanding of the warning signs, the symptoms, and then the management of these symptoms, so that people being more comfortable to know what are the symptoms and to talk about it. It becomes less of a stigma and less of feeling ashamed about it. So the more we can do that, the more we help the community as a general to support each other and to discuss this condition, because it is so important to get addressed. So increasing public awareness and increasing their adequate understanding about the disease. It's not a death sentence, but it does indicate a progressive decline. So we need to be prepared about it ahead of time. Right, so these are things that I think it's important for people to feel more and more comfortable to talk about them. And then finally, as far as my field, is to develop more culturally sensitive assessment tools so we can do a more accurate assessment of their cognitive abilities. So these are things I think both a community in general and us providers would have to keep in mind in order to serve a wide, diverse population.
Thank you so much, Dr. Han. I know you also provided some resources, but we're going to get to the resources, if not at the very end of the program. We're going to be distributing all of the program material so folks will get the resources that you've listed. I'd next like to bring up Dr. Amina Johnson. So when we move on to Dr. Johnson. Good evening, Dr. Johnson.
Good evening. How are you, Michael?
Fine, thank you. Can you share a little bit more with us about your background and interest in dementia and Alzheimer's?
Sure. My name is Amina Johnson. I am the LGBTQ liaison in Montgomery County, and I work to support the LGBTQ community. I have a background in actually higher education, where I focused on training higher education leadership on the needs of LGBTQ students in education. And so there are two reasons that I am interested in this work. One is a pretty personal reason. Personally myself, I was fortunate enough to be raised by my great grandmother, who lived to be 99. And the last 7 years of her life, she had dementia. And I was living in the house with her and of course was helping to caretake for her. And so ever since then, I've had an interest in making sure that people learn about the signs and all of that of dementia. The other reason that's related to LGBTQ elders is I used to work in foster care. I used to work with LGBTQ youth in foster care for the Department of Social Services in Prince George's County. And I can't tell you the number of times that Adult Protective Services would come to me looking for resources for older adults. And there weren't many, and there aren't many programs for focusing on older adults. And so that's the other reason that I'm interested in this.
Thank you so much. So speaking of the elder LGBTQ community, what are some of their issues or considerations when we think about the LGBTQ community, particularly those from the 50s and 60s, those clearly who are 65 plus, who have experienced the first wave of discrimination and issues of hiding, unfortunately, in the closet? I mean, what are things we need to be more sensitive to in dealing with this community?
Sure. You know, there's several considerations, but I think the two that really go with for this community is for those that are in their 50s and their 60s and even older, because they're LGBTQ people who are living just as long as everyone else, there's a real fear of discrimination. And I think a lot of times in 2023, we think, you know, things have changed, people are more accepting, providers are more accepting, which is true. However, we're dealing with people who could have lost their jobs, could have lost their home, could have been kicked out of their families for even just the thought that they were, LGBTQ. And so people will delay care because of a fear of discrimination. So I think that that is a consideration that folks need to think about in making sure, and I have some recommendations later about how to make sure that you are welcoming. But also I think as a family member, I think sometimes as family members, we may assume that, oh, well, grandma is taking care of herself. And she's always, but this might not be the case. The other thing is ageism, and I spoke a little about this before, but not all LGBTQ people are young people. I think when we think about LGBTQ activism, we think about young people protesting and that sort of thing, but LGBTQ people age just like everybody else. And many activities and communities are centered around young folks and the education of young folks for issues that young people deal with. And dementia is not usually something that young people deal with. So there's not a lot of education out there about dementia and Alzheimer's in the LGBTQ community.
So it sounds like even within the LGBTQ community, becoming more sensitive and open to the elders, those who were the trailblazers, if you will.
Yeah, I think there is this sense of being open to the elders and honoring them, like look at the trail that you've blazed, but there isn't the sense of what happens once we get older. We can honor you, but taking care of you and making sure that you age gracefully is something that hasn't been centered, I think, in our community. And I think we're still at a stage where the elders in the community aren't as open as the younger folks. And I think sometimes people take that for granted.
And I would imagine with our elder community, given what happened with the AIDS epidemic in the 80s and 90s, there's some tremendous discrimination and stigma. And again, that first wave, I mean, they were subjected to so many things. I would imagine it's hard to feel truly comfortable acknowledging yet again another major illness that's impacting the LGBTQ community.
Exactly. I think that's another thing. I'm glad you brought up the AIDS crisis in the 80s and the 90s, because for a large part, the LGBTQ community were taking care of themselves during that time, right? And reaching out to our internal networks. And because of the discrimination, because of the stigma. And I think that when it comes to dementia, sometimes people think, well, we'll just handle this on our own in our own little community because of the past discrimination and dementia. And it's something that really we don't have to do anymore. We can reach out in the community, and I think that that's a good thing.
Okay. So speaking of reaching out, what recommendations would you have for practitioners and caregivers, both caregivers within the LGBTQ community and just neighbors, the regular general community? How can we be supportive as allies, as neighbors, as church members? Can you speak to some of the recommendations?
I sure can. Most of these recommendations, I think, are for everyone. A few of them are more specific to providers, but this first one, expand your definition of family. And I think this goes for people of color communities as well. Family isn't just your biological family. Family spans far beyond that. And for many LGBTQ folks, even if they themselves have not experienced their families turning away from them, they've taken people in, right? And so expand your definition of what family may mean. Also, some LGBTQ people, even though marriage is legal across the country, some LGBTQ people may not get married either because of stigma or other things. And so they may have partners and that are not their spouses, that are not their legal spouses. They may call someone their daughter or their sister, and they may use that type of biological language but then the person comes in, and either because of the age of the person or maybe even the race of the person, that might not be what you think their sister or their daughter to be. And so expand your idea of what family is, of course. And see LGBTQ people, I think especially in 2023, when it comes to allies of the LGBTQ community, we want to go, we're going to treat everybody the same. I don't care if you're LGBTQ, if you're straight, if you're cisgender, if you're trans. Yes, that is wonderful. But By doing that, sometimes you actually push LGBTQ people further into the closet and kind of hiding. If LGBTQ people don't hear that they're welcome, they won't know that they're welcome. So you need to see them and acknowledge that you're open to LGBTQ folks, but also acknowledge some of the challenges. Like you said, Michael, you've brought up many times in this conversation that those older LGBTQ folks in their 50s, 60s, and above, they've experienced some challenges that were real, right? And we need to acknowledge that and acknowledge the trauma that may come with that. The other thing is providing support. And I think this is providing support to the LGBTQ people themselves. So if they are an LGBTQ older adult, making sure that they can have things where they can meet up with their peers, right? If there's a provider, I think the other thing that is not considered is that LGBTQ children are caring for their parents. And so sometimes it might not be the parent that is LGBTQ, but the caregiver may be LGBTQ. And so as a provider, you need to think about that and expand your definition of family and that sort of thing. My wife is my mother's daughter-in-law, right? And so if I say, daughter-in-law, like that might be like, what, your mother's daughter-in-law, what are you talking about? And that sort of thing. So I think making sure that we provide support for LGBTQ people, as well as the caregivers that might be LGBTQ. And then the last three here this is mainly for providers. Make sure that you educate your staff around LGBTQ cultural competency. Make sure that, you have training, because that is the foundation for excellent care on anything, not just LGBTQ folks. But yes, there needs to be some LGBTQ cultural competency. I often, when I do trainings, I say, I've been doing these trainings for good 15, probably closer to 20 years. 10 years ago, even, I would do some trainings and people have struggled to even know what the acronym meant, right? And in 2023, most people do know what that acronym means, but some people don't. Like, you have more of a variation, right? So just make sure you provide training. Even if you think folks know, make sure they know and understand. A really important one is to mirror language. You want to mirror the language that people use. So a lot of times in 2023, we want to say your spouse, your partner, your husband, your wife. Older LGBTQ folks might not use that language, mainly because it was unsafe, back in the day, to say, this is my girlfriend, boyfriend, partner. So they might say my friend or my roommate, and they may, you may know what they mean. And, you might be like, it's okay to say your partner, but they may not be okay with that. They might not be out to their caregiver. Let's say their caregiver is their child or their brother or their sister. They may not be out to them. So use the language that they use and mirror the language that they use. Listen to the things they say, respect, communicate, and be interested and open. The last thing, and Michael, I don't have to say much about this because you did an excellent job at the beginning of this talk, talking about having a holistic approach. Just remember that LGBTQ people have other identities too. They have a race, they have a gender, they have a social economic class. And so while their LGBTQ identity may be causing some stigma, some fear with them, their racial identity or their gender identity may be doing that as well. And to remember that, I can use myself as the best example. I'm a Black woman and I'm also a lesbian, right? And so I've got all of those identities going on. So when I go in, if I were to go in and seek care, I would hope people would see me as that whole person and not just one piece of my identity. So those are the recommendations that I have.
Thank you so much, Dr. Johnson. We really appreciate it. Now let's engage Dr. Flavia Walton. Dr. Walton, good evening.
Good evening. How are you?
So first question too, share a little bit about your background and your engagement in the dementia Alzheimer's situation.
Certainly. Well, it starts with undergrad with the double major in sociology and economics. And you wonder about, what does the economics piece have to do with it? Well, in today's world, everything. Graduate school was all rehabilitation counseling, then rehabilitation administration for the doctorate. I, however, choose to use the term habilitation as opposed to rehabilitation. My philosophy is to take people where they are, accept them where they are, and work with them from there. And you are enabling them to be the best that they can with whatever they bring, and to live the best lives that they can with whatever abilities that they have. And of course, this is very important with dementia, which I learned firsthand with my grandmother, my father, and my mother-in-law, all of whom had Alzheimer's.
Hmm.
I learned through being baptized by fire, essentially, because there was nothing in my academic training to prepare me for what I encountered in real life. But understanding that as they progressed in their disease, what they did realize was how people made them feel. So that became very important in terms of understanding the complexity of the disease. They may not have always recognized who I was, but they knew, I could tell that they knew how I made them feel. So it became very important to me to always make them feel the best that I could make them feel, so that they would still have those memories. Now, as I've learned more about the disease, I know that that part of the brain that enables people to feel is one of the last parts of the brain to be destroyed by the disease. So as I go forth and as I work with individuals and helping people understand the disease, that's one of the primary lessons that I want them to learn. It's how people will always know how you make them feel. And it's important for everyone to feel respected, accepted, and accommodated. So those are the things that I think that I've learned most, and try to teach and try to share.
That sounds wonderful. Sounds very comprehensive and humanistic in terms of engaging folks, which again, dealing with communities of color is very critical. We are a collective of a whole host of religions and spiritual and cultural and being, again, as Dr. Johnson said, very holistic in our approach. So let's talk about some of your slides.
Yes.
Your first slide, you talk about aging. And I know aging can suggest a number of different things to different people, but can you talk a little bit more in particular about that?
Certainly. First of all, I think we need to start with a very basic kind of notion, and that is aging, like everything, happens within a cultural context. We exist within a cultural context. There's nothing that we do that is without culture. All of us are multi-layered in culture. Each one of us belongs to different cultures. It may be our racial identity, our ethnic identity, a religious identity, a familial identity, a social identity. All of those things carry certain cultural contexts and traditions. So we all become a combination of all of those things put together. But we are also individuals. So when we encounter individuals, we have to treat them as a unique individual. One size does not fit all. I am like nobody else. You are like nobody else. So we're each unique in our own being. So that has to be taken into consideration. And African Americans are not a homogeneous people, as many people attempt to define us. You know, they define us as being, you know, everyone's the same. No, we are not. We have the same kinds of social structures, educational definitions, all those kinds of things as all other cultures. They may look differently, they may behave differently, they may play out differently, and they may be treated differently. But the differences do exist regardless. So aging is also part of that cultural context. And that aging context is cultural context is treated differently by different cultures. So that's something we also have to understand very, very clearly. Some cultures accept aging as being something very noble, something that's respected. Others, you know, people are put aside as they become older. So we have to understand where people are within their cultural context. The kind of care a person receives as they age is also very important. It's everybody does not have the same access to care, as has been mentioned by the other presenters as well. As African Americans, our access to care is often defined by our ability to pay, where we live, our beliefs about healthcare, all of those things, and how people see us in terms of the kinds of care they feel we ought to have or we deserve, without thinking about who we are as individuals and what we deserve for being an individual and being a human being. So it's very, very important that we understand that disparities exist. They are real. They impact families, they impact individuals, they impact communities, and they impact society in very negative kinds of ways. So we have to do all that we can, particularly as we're talking about dementia, Alzheimer's, all the different kinds of dementia, that we have to pay very, very careful attention to access and improving access wherever we can. There are parts of Washington, D.C. that do not have healthcare for residents. And when you start talking about specialized healthcare for individuals with Alzheimer's disease, you're really out of luck. Number one, because there's so few people who have those special kinds of qualifications, and then where they exist usually are not in a place that has easy access to our communities. So those become very, very important kinds of issues. Many individuals have no input into the kinds of care that they receive, either now or later. So that's important. What kind of legal advice is available to them in terms of making those kinds of decisions? There are stigmas, there are myths, there's shame attached, there's a misplacement of identification. They're often seen as being crazy or having a mental illness, as opposed to having a brain disease, a disease of the brain. Assessments are often disparate for us. For an example, in some of the most basic kinds of memory screenings, there can be discrimination, for an example, and cultural kinds of things as well. If a person has no place to go, why would they need to know what day of the week it is, what date it is, or even what time it is? Think about that. I mean, and that's very real. That has no implication necessarily on a person's ability to function cognitively. It's what the particular needs are for the person to maintain that usual lifestyle within that particular cultural bent. So there are many, many things to consider, in addition to Black women are 2 to 3 times more likely to have Alzheimer's than anybody else. Now, imagine the impact on families, especially when women are the primary caretakers. So what does that do to the upheaval of a society, or to a culture for that matter? The impact of COVID. I'm sorry, go ahead.
No, I was going to say, it's interesting what you mentioned in terms of what's called, I believe, the mental status, and certain questions are not culturally based, or they make no sense. That gets at the whole issue too of, again, the healthcare system, whether we're talking about healthcare providers, physicians, what have you, or those in assisted living or nursing home facilities. Can you talk about support teams and maybe who needs to train them, or what needs to happen in those kinds of settings?
Yes, absolutely. I think throughout the healthcare system, there needs to be a realization that different kinds of training with an emphasis on cultural competency is important. And it's not always the professors that provide the best kind of training, but sometimes it's community-based people, community people that know the community, that know the cultures that are operating within the community, that know the language, that know the information brokers within a community, know the resources that people have, know where people go to get information. Those are all very important kinds of information to have when you are treating people in any kind of health situation. when you are helping people make the best of their particular life with whatever abilities that they have. It's important to know those things. It's important for healthcare professionals to know language, and that's been emphasized by the previous presenters as well. It's very off-putting if a healthcare provider or anyone goes into any kind of culture and tries to automatically speak the kind of language. I mean, that's very off-putting. It comes across as being false, as being very offensive, really. But understanding what people are saying, that is, I think that's the key, as opposed to just trying to be hip or, with it, or that kind of thing.
So it sounds like approaching individuals with a sense of humility.
Yes, that is very important, and not putting yourself on a pedestal, but being with people. You can be knowledgeable, be helpful, and be really significant in a person's life without being superior to a person. Kind of the thing that many of us grew up with in the African-American community, there before the grace of God go I. And that's kind of the philosophy I think many of us have to approach what we do.
I think, Dr. Walton, you had a slide that talks about who trains the support team. I don't know if
Yes.
pull that up for a second. I know we've hit on some of those points, but why don't we pull that up too, just to make sure we've touched upon some of the critical things that you were saying.
Yeah, what's already in place? What's there to enhance the understanding of cultural differences?
Mhm.
What are the nuances and importance to supporting individuals who are aging in place? Are there current standards or requirements or supervision of support team to ensure that they are doing what they need to do culturally, that the cultural competencies are in place? The respect and the accommodation as well. You may be culturally competent, but not culturally respectful or accommodating. So those things have to kind of go together. And the family was mentioned earlier. The traditional family is not always traditional with African Americans because of health issues among African Americans. Death has happened at different times for us than other people. So our families have often been broken because of early deaths or illnesses or other kinds of issues. So family becomes something different. There may be no blood relationship at all, but that family is just as important and just as close as perhaps the traditional family, so to speak. So know who that family is, who's part of that family, and the role that they play with individuals. Are they involved? That's the other thing. And that's something that our healthcare system and our legal system as well fails to acknowledge all the time. They don't always acknowledge those people who are closest to us and who are really in the best position to care for us and to make decisions for us. And they're often cut out of those decision-making processes. Our individuals given space. Mm-hmm.
If you don't mind, Dr. Walton, I know we want to bring Dr. Salazar into the conversation in a moment, but one of the things I think you point out too, whether the family's involved or other individuals, when somebody's got the diagnosis of dementia or Alzheimer's, I mean, how should they be treated? I mean, we put them in a corner. Oh my God, they now have this god-awful illness that, will lead to their demise, or how should we engage them? You want to talk a little bit about that slide that talks about keeping individuals involved?
Yes, and I think we have to try and maintain as close to what they were once doing as being normal and before they were diagnosed with the disease as possible. What activities were they involved in? You may not be able to do them on the same level, but some activities that resemble what they were doing. Their favorite leisure activities, church, social service organizations, favorite music. Music is a real important piece. Their friends, keep their friends engaged. Social engagement, keep them engaged with other people for as long as possible. And don't make assumptions. Their activities must reflect the traditions within their culture and what they had been accustomed to doing. And again, one size does not fit all. And remember that they may have been part of fraternities, sororities, or whatever. These are very important people in their lives. Keep them engaged with the people with whom they associated before. If there were sorority hymns or songs or fraternity hymns or songs, play them in the background, let them stay engaged, let them feel those things for as long as they can. Keep them in touch with what they knew for as long as possible.
Thank you so much, Dr. Wall. Those are very helpful ideas as we're keeping our loved ones engaged. They still are breathing, living individuals who have a spirit, have an essence to them. And frankly, correct me if I'm wrong, even though they may have the diagnosis of dementia or Alzheimer's, it's still important to keep them engaged. It still helps stimulate what's left of their functioning, correct?
Yes, and for a long time, they can still lead a productive life.
Right. So thank you so much. I know you've got some recommendations as well, but again, we're going to provide all the list of the recommendations at the end of the presentation. I'd now like to engage Dr. Andres Salazar, if we can bring Dr. Salazar into the conversation. Good evening, Dr. Salazar.
Hi, can you see me?
We can hear you. Steve, if we can assist Dr. Salazar with bringing up a visual, that would be great.
Yeah, Dr. Salazar, were you trying to share a slide?
Okay, no, I don't have slides.
Oh, okay, so then here, let me just pop you up there. There we go. Okay, we can see you perfectly.
Right.
Good evening, Dr. Salazar.
No, happy to be here.
So Dr. Salazar, can you share with us a little bit about what is a geriatrician and what does such a medical specialty do for seniors, and specifically seniors with Alzheimer's and other forms of dementia?
Yeah, basically my primary specialty was family medicine. And then after I finished family medicine, I completed a 2-year fellowship in geriatric medicine. Basically, geriatric medicine is the internal medicine of the elderly.
Okay.
And basically it deals with all the complications of chronic diseases, including mental illness, degenerative brain diseases, Alzheimer's disease, and the multiple related disorders. Syndromes that are quite specific for the elderly population, like urinary incontinence, mobility problems, osteoporosis, chronic pain syndromes, cognitive impairment, as I said before, and issues that may not be important for the younger population, but are quite important for the elderly, including chronic constipation and incontinence of bowel or incontinence of bladder, that usually the younger population take those for granted because they don't have the problem. But as we age, we start having problems with our GI tract and with our urinary system, and elderly people end up with becoming isolated because they want to go to an event, but because they suffer from incontinence, basically they become isolated because they're afraid to go out because they may have an incontinence episode. Not to mention the elderly that suffer from progressive cognitive impairment and from isolation. Isolation because they don't have family members or they live by themselves, or isolation because people know that they're cognitively impaired and they put them aside. It's a kind of discrimination that is very subtle, but is there for the elderly population.
So it sounds like for the elderly population, there's some serious real medical challenges. And as a geriatrician, you have a unique focus on those medical conditions that often get overlooked. Why don't we talk a little bit about the Latino community, particularly, what are the challenges for Latinos with dementia when it comes to nursing homes and the language issues? Can you speak to some of that?
Yes, absolutely. I would like to start by saying that my experience as a geriatrician is working in institutions. I have never opened a private practice,
Okay.
I have served all the communities in the setting where I practice. I practice in nursing homes, in assisted living facilities, in post-acute care centers where they provide rehabilitation and they also provide long-term care. I have practiced as medical director for continued care retirement communities. I have practiced in adult daycare centers. I have in some settings in continued care retirement communities. I have done the outpatient visits for the patients who live in the independent part of the continued care retirement community, but I haven't had like a direct contact with the Hispanic population. I have cared for the Hispanic population in the nursing homes, but just a few patients. Most of my patients are basically diverse. I have been taken of Caucasian patients, Asians, African Americans, Europeans, and the Hispanic community that has been growing, I would say, significantly in the state of Maryland. As I said, I have had contact with patients and have taken care of patients with Hispanic patients with dementia in nursing homes, and I will be able to relate my experience that I have had with these communities. But I just want to piggyback on what the speakers have said before. Especially in minority groups, we found the same issues. We find issues related with education, issues related to lack of accessibility. Many of the patients that I have been taking care of within the Hispanic community, they don't have insurance. And then when they call me and I tell them, hey, I don't work in the community, I work in institutions, I refer them to a primary care provider. And that's basically an undertaking because sometimes they don't have the money. Sometimes some of them, a few of them may not have documents. The green card may be in the process, and they basically, they get lost in follow-up. I have had patients with dementia that have approached me, and I have referred them to the Maryland Access Point, and they see them there for 2 or 3 appointments, and somehow they get lost in follow-up. When I check on them several times on the phone, sometimes they don't answer the phone calls. In a few occasions, I have been to his house, knocked at the door to see, hey, what happened with my referral to the Maryland Access Point, and they don't even open the door, maybe afraid that I'm going to report to any agency. And basically, that's one of the issues. One of the major issues with the Latino population that I have served in Maryland is that they may have issues with immigration services, then they don't want the services, because even if the services are provided for them, they might be afraid that they are deported back to their countries. I have seen several patients from Central America, from Mexico, from El Salvador, from Honduras, and sometimes they don't want to go to these organizations like the Maryland Access Point because they're afraid that they will be reported to the immigration authorities. Others don't have the money, others don't have the insurance, others don't have the resources, or don't have extended families. I have seen patients where, just to give you an example, that I was—
If you don't mind me interrupting for a second, Dr. Salazar, so how, from your vantage point, dealing particularly in nursing homes and other facilities, how do you build the trust for these types of families having that level of suspicion so that they can get the services? And I wonder, whether in nursing homes or assisted living facilities or other healthcare facilities, how do you build the trust for them? And also, how do you deal with the language issues that often, I would imagine, is a major barrier when English is not their first language?
The issue with the nursing, with the Hispanic patients that I have encountered in nursing homes, they're a different community because at least they have access to care. And the reason they end up in the nursing homes because they have a catastrophe like an episode of congestive heart failure of a urinary tract infection that became urosepsis. They ended up in the hospital. The hospital will send them to a nursing home because they have cognitive deficits, because they have functional deficits, and they end up with me there. At that stage, the rapport is good, and the education that I might be able to provide is great. That population is okay because it's a controlled population. The major issue that I have had that I haven't been able to reach because I don't work in the communities is the Hispanics that are there that don't have insurance, that do not have a primary care provider, that don't have the education, that English is basically a barrier because some of them may speak broken English. Others, because they live with other Hispanics, they don't have the need to speak the language. But once they get sick for the first time, they realize that English is very important to live in the United States. That is the community that I haven't been able to reach, but the Hispanics that I have been in contact with and I have worked with in nursing homes and in rehab centers, no, they are other category of the Hispanic community. Okay. They have a higher level of education, the socioeconomic status is higher, and the families understand the process, and the families wants to help and to support their loved ones affected with dementia.
So it sounds like families who may be second or third generation in this country, they have better understood the American context and they're better able to access services and that sort of thing. But can you speak to, again, recent immigrants, recent individuals who have come to this country that language is a barrier? And even and I know Dr. Walton kind of talked about this in terms of training support personnel. What do you do when it comes to training healthcare providers to have them better understand, be sensitive, be more culturally competent? Can you speak to some of that?
Yes, absolutely. I think I've been a member of the Alzheimer, the Virginia Jones Commission for Alzheimer's disease and related disorders. We basically, on 2012, drafted the dementia plan for Maryland that we sent to President Obama. And 2 years later, the governor created the council, and I had been part of the Virginia Jones Council for Alzheimer's disease and related disorders. And one of the goals of our council now is to get university centers, the schools of nursing, the schools of physician assistant and nurse practitioners to basically to coordinate the curriculum. So we want to make sure that our medical students, our residents, our new physicians have the awareness that dementia is a problem, that we need screening tools, that we need support groups, that we need an entire team to take care of the problem. But as of now, the university centers, they basically work in general, independent of other groups that try to provide support groups to the community. Then basically we need to link dementia education to support groups in the community. That's one of our goals now with the commission.
Thanks. That's wonderful. I'm glad to hear that. So speaking of that too, I know in the Alzheimer's Association, I believe we have Karen Fagan with us this evening. And Karen Fagan is the Health Systems Director. Very quickly, if we can bring in Ms. Fagan, can you share what the Alzheimer's Association, in view of your role, Ms. Fagan, is doing, and in view of what Dr. Salazar was saying in terms of how do we engage nursing schools, medical schools to bring up better training, cultural competency, things of that nature. Ms. Fagan?
Yes, thank you, Michael. Well, the Alzheimer's Association currently works with clinics in the community, focusing on underserved clinics to educate primary care physicians. As the physicians have mentioned, primary care is the first line where patients go. So we want them to be more comfortable in terms of diagnosing this disease, how to go about the testing, what that pathway is, and their teams to be comfortable in developing a comfort level to talk with the patients, to talk with the caregivers. So not beyond the physicians, to include nurses, social workers, and to understand the cultural sensitivities that are needed, and also to kind of step back and do all of this in coordination with what really matters most to that patient. What's going to make them happy? What is their goal? And so this is kind of our focus right now. It's an education series, again, focused on underserved communities. And that's really where education stands community-wise. We do also work with health systems to educate them in terms of how they want to address the older patient as they walk in the door, whether it be in the ER or on a unit. So again, getting back to what matters most to that patient so that hopefully we can improve outcomes as well as enhance that patient experience.
Thank you so much, Ms. Fagan. So it sounds like, again, it's critical, Dr. Salazar, it sounds like it's critical to be able to engage the healthcare community to make sure that they're fully cognizant of what's going on, cultural competency, cultural sensitivity, understanding the nuances within the Hispanic and Latino community. I've got another question for you too, Dr. Salazar, if we can bring Dr. Salazar back up. We've talked about, your concerns, Dr. Salazar, in nursing facilities, in assisted living facilities, the quality of care, the understanding. Can you speak some to, given particularly in the Latino community, as is the community, other communities of color, can you speak to the familial value of caring for loved ones? I mean, how can those outside the healthcare system, if you will, be of assistance, be a resource? Dr. Salazar, if we can bring up Dr. Salazar up.
Yes.
So how can we engage communities, family members, neighbors, to help those that have yet, given what you were sharing earlier,
Sure.
the suspicions around doctors and what have you?
Let me tell you my experience regarding this. When I moved to my neighborhood here in Ellicott City,
Okay.
I was a young couple with my son. He was 4 years old, and everybody in my street was probably older than 70. Everyone was seniors. There were no children. And my son, 25 years ago, my son was the only child in the entire neighborhood. And I noticed, being a geriatrician, I noticed that there were some patients declining. In fact, my next door neighbor, she was like 91, 92, and she had Alzheimer's. And several times they called me in the middle of the night because of falls. And my wife also helped this family for a few years. And we were able to keep this lady living here in her house, in the community. And she never went to the hospital. There was another patient also in front of the house that developed Alzheimer's disease. With the support of a few neighbors and my wife and myself, we were able to keep this person in the community. We have another lady that was 97. She, at the age of 97, she was still driving. But the scary thing is that she already had early Alzheimer's disease. I think my advice for the community is that we need to get involved. We need to get involved in our neighborhoods. We need to look for our extended family. Let's see that a family has someone with Alzheimer's. They need to look for, for extended family that is willing to help to keep their loved ones in their communities at home. You need to look for friends. You have to advise them about the support groups. Something that I wanted to tell you about support groups. For instance, my son, he's a nursing home administrator. He wanted to be it's called a support group, a volunteer for a support group facilitator. Mm-hmm. And I remember that he was going to Baltimore, like in Orleans Street, like 4 blocks from Johns Hopkins Hospital. And he went to this library, and initially he had like 2 or 3 people. He used to go every week. And after 3 or 4 or 5 weeks, only 1 person was going. And he told me, Dad, if it's only 1 person is worth it. But he had to quit the group because for 3 or 4 consecutive weeks, no one showed up, even though the volunteer was there. But I don't know what happened, that he didn't have patience to help or to support. Then basically he never went back because he didn't have people to help. Then that's something that we need to discuss with the Alzheimer Association and with these groups, how to make this group successful. You have volunteers, but at the same time, we have to make sure that the community is aware that we are there to help them.
All right, that's a good segue. Thank you so much, Dr. Salazar. I know we're at 7:10. We're going to need to probably wrap up at this juncture and open up the conversation for questions. But and we'll talk about this in a minute. How those on this evening's Zoom, how you can get involved. What can you do, as Dr. Salazar said, as members of your community to help your neighbors, to advocate, to ensure that drugs are available that's going to help slow down the illness, to provide education, informing people is so important. But let's get to our questions. We have Sheila Griffith and Laura Byers. They're both program managers with the Alzheimer's Association. They've been monitoring the chat room. So why don't we open it up now to the chat room and address any questions that might have come in.
Thanks, Michael. So we do have we had a question come in pretty early on, and it was answered, I think, in the Q&A, but I wonder what the other speakers might have to say about it, and it's cultural barriers. Now, we talked a lot about that, but specifically how to assess a doctor's experience regarding dementia for a particular race, gender, ethnicity. And is there a database that kind of shows you doctors' experience that way? And Dr. Hahn had some feedback in the Q&A, but I wonder about the other speakers. What do you think about that question? How do we assess the doctor's experience regarding dementia? And if there's a way to do that. And maybe Dr. Salazar, you're on, so maybe, do you have any thoughts on that? your camera's on.
I think this is an undertaking. I think most doctors don't receive enough training in the management of patients with dementia. They don't even know the screening tools. You may talk to a doctor about screening tests, something like we use every day, like the MOCA, the Montreal Cognitive Assessment Tool. Most doctors, primary care doctors, they don't even have experience. And when they have a patient with dementia, most of the time they refer to neurology. And not all neurologists, people think that a neurologist is the right person to assess a patient with dementia. If the neurologist wants to see and like dementia care, they will be good clinicians or good fits for the family. But my experience is that most neurologists, they're not interested in having a long-term relationship with the patients. I have seen more, I think more success with geriatricians and with psychiatrists. For the most part, geriatricians and psychiatrists, they're more interested in having a long-term relationship with the family and with the patient and help. Okay. And the other thing that I forgot to say is that when I drive in my neighborhood, sometimes I see the signs, adopt a road. But I think to myself, why not to have a sign that says adopt an elderly person, adopt an elderly person with dementia? There is something that I cannot reconcile with myself every day, is this apathy, this indifference for the suffering of other people. And during this pandemic, I felt the same thing. I suffered a lot because I noticed the apathy of human beings for the pain in others. I think we need to basically help our communities. We need to be part of our communities, and we need to grow with our communities. We need to finish this apathy, this indifference for our fellow man. And that's the major problem that I see in my communities right now.
That's a great statement. That's amazing to be able to adopt our neighbor, just as we, put our time, love. We talk about being community and being human beings. I think it's important, as we're being human beings, to engage others, to reach out and support. That's at a minimum, it's being neighborly. That's a wonderful point, Dr. Salazar. Are there other questions in the chat, Laura or Sheila? I
just want to draw everybody's attention, or Dr. Hahn, maybe you can repeat it, but you had you have a great point, which is to just maybe asking the doctor directly, you know, whatever doctor it is, what their experiences are, and maybe, you know, having maybe your loved one who has a diagnosis can't ask that question directly, but we as family members, or and as we heard, there's all different kind of family, but as going with a loved one to the doctor and asking directly. I don't know if you can say anything about that, Dr. Hahn.
Yeah, and I really like the statement Dr. Salazar made as well. I think as a provider, we really need to think from our perspective of what we can to provide for the patient that comes to our offices. And I think in terms of being able to just listen and being available for them to learn from their perspective what they notice and be curious, that's how I usually apply the approach, because even if I speak the language doesn't necessarily mean that I share the same background. And I think it applies to other cultures as well. I work with African American, the LGBT group. I think it really helps me to just be humble and be willing to listen to them and mirror their language and being able to allow them to share with us. And I think that is a very critical skill for providers, for healthcare staff members to have. Is not just to assume and come in with an attitude of I know it and you don't. I think it really is to speak their language and to understand them. So from a client or a patient perspective, if you notice your provider is willing to listen and willing to learn from you, I think that is a good sign. And if you could ask them if they have the experience, and even if they don't, if they are willing to learn from you, that is also something you can consider. But if they're not, I think maybe you could just politely ask if they can find you somebody else that might be, more experienced in working with a particular group.
Mm.
So I think communication is a very important key here.
And I wonder, Dr. Walton or Dr. Johnson, if you have anything to add in this regard.
I think I see Dr. Walton's comment, and I think that depending on community members, I think in the LGBTQ community, word of mouth, what providers are you using? Are they LGBTQ open and affirming? I think in all of the communities asking, have you been to a provider, and how well do they work with folks with dementia? I think we depend a lot on the reviews, if you will, of our friends and community members.
Yeah, Dr. Walton, you made a great point in the chat. Real dementia care may rest in the community, perhaps partnership with the health community. So how do we engage that? I don't know, Dr. Walton, if you have any quick thoughts about that.
Yeah, I do. And I think that some of the best attention for people with dementia is community-based, the kinds of things that they really need to remain on functioning as best that they can. Yes, they need healthcare, absolutely. But I see that there can be a partnership between the community-based programs or community-based activities in which people are engaged along with healthcare providers. I think that would be an optimum kind of a situation, because healthcare providers are really kind of geared by what insurance companies tell them they can do. And insurances don't always support dementia care as they should be cared for, but the community can take up the slack. The community can provide a lot of activities that go hand in hand with healthcare. So I think that that's kind of a natural relationship that should be explored further, and perhaps even tried on just have some pilot programs out there to see what can happen.
I know one of the program managers mentions that local community villages are trying to be as supportive to local neighbors too. And I think in the District of Columbia, there are some community villages that folks are trying to gather, provide services in terms of food, medical, checking in on neighbors, things of that nature. And I even wonder, through some of our community centers, whether in Prince George's County, Montgomery County, or the District of Columbia. How do we engage our recreation centers and others just to maybe check in on our seniors, check in on providing health and other kind of medical checkups or check-ins as a way of getting at providing support and engaging the community in a different sort of way as well?
Yeah, absolutely. But I think that even recreation centers and places like that can also, people there can receive training in terms of doing things
Right.
for seniors. I mean, and this is really important to have these kinds of activities in communities that are accessible to people who need them. At churches, community centers, social organizations, et cetera, wherever people are, wherever people exist that reach people, that's where the rubber meets the road, in my opinion.
If I can just add, we have seen in providing programs to community villages, to community villages, and that they are really partnering with the faith organizations because they know that that's where people are going to, and so that's their audience. So I have seen a transition to groups being more flexible about partnering with all kinds of organizations to reach more people where they are, as opposed to waiting for them to come to the community village.
So we have another question in the Q&A. Laura, do you want to ask that one?
That one is about first responders.
Right. What approaches would the panel suggest? I can do it. What approaches would panelists suggest to help? I don't know if everybody can see it, to help establish comfort, respect, trust within those critical first 30 seconds to 2 minutes when you're a first responder. That can be very critical. Obviously, how do we do that in our communities?
Would you
We
tell
have-
us? Give us more
We have
detail
8
about
minutes
the
left. I don't know we can
circumstances.
do that in 8 minutes.
Take turns.
I'll
I
say
think-
something. Oh, sorry.
I was going to say,
Go ahead.
I know in Montgomery County, there's an Officer Reyes who's done some work with individuals with developmental disabilities. I think also people with dementia. So in terms of first responders, making sure that they're trained in those areas that they don't have first responders like police officers trained, maybe seeing if there's partnerships with their mental health units to bring in those kinds of specialists who could approach an individual in distress in an open, respectful way with eye contact and some of the things that the questioner raised. Because again, if you're approaching somebody in kind of an aggressive manner, that might heighten their level of suspicion or paranoia, particularly, again, depending on what the medical or mental health or cognitive issue might be.
Yeah, I don't know if Dr. Salazar, if you I think you were going to say something, and
Yeah, I just wanted more details, but when addressing someone with severe behavioral disturbances with dementia, basically we always have to ask the question is what's triggering the behavior? Sometimes could be pain, sometimes could be loneliness, sometimes could be hunger, sometimes could be cold, sometimes could be fecal impaction, sometimes could be urinary retention, sometimes could be an acute illness. Then we need to be very careful because many times, even in institution and in the hospital setting, a patient with dementia develop changing condition, develop aggressive behavior. And the first thing that the nurses or the physicians do is to order 1 milligram intramuscular of Ativan or give the patient an antipsychotic, but that's not the solution. I always teach my nurses and the fellows and the residents and the physician, you always need to look for the cause. Yes, we know that the patient is demented, but what is triggering the behavior.
Yeah.
Typical example, a few years in a nursing home, I was writing my notes and was an elderly person in the wheelchair banging at the door. I want to go out, I want to go out. And the nurses and the personnel were completely oblivious. And this guy was causing too much commotion within the unit. Other patients got agitated. And then at some point I said, well, we need to stop that. I told the nurses, how come you sit down there and you don't care that this guy wants to destroy the place? I called the activities department. I said, send me someone from activities. They came, they opened the door, they took the elderly person with dementia outside for a ride. 20 minutes later, there was no crisis, and the guy went back to his room with no issues. Then it's not giving the patient, in this case was probably boredom and isolation that triggered the whole episodes of violent behavior. But many times could be pain. Many times could be that the diaper is wet with soaked with urine, or sometimes the diaper is soiled with fecal material. Always look at the cause.
What about Dr. Johnson? You were also, I think, going to say something in maybe in the community, you know, first responders. Any thoughts?
Yeah, I think, you know, in the LGBTQ community is that, you know, make sure you are responding to people in the way that they want to be responded to. So make sure you're calling in their proper name. Or if, you know, if there is a different name on your paperwork and you have been told to call them the name that you have been told to call them. I think to Dr. Salazar's point, like if someone has, you know, their name is Susan, but on their paperwork it is Robert, and you just call them Robert, and, you know, then that might set off an episode for a transgender, you know, person. If you are not acknowledging their partner or something like that, I think that those are some split-second decisions you can decide to make, that this is what I've been told their name is. I've been told that this person is this relation. I'm not gonna ask questions. Sometimes I think first responders sometimes can get too caught up in the black and white of a situation, and they make it worse than it needs to be sometimes.
I think too that a lot of it boils down to empathy and respect. Wherever you are, whether it's police, whether it's healthcare, whether it's social services, research, it doesn't matter. It's empathy and respect. If you don't respect the person, the culture, whatever, if you can't have some kind of empathy for that person, that culture, that research, whatever, it's not going to mean the same. It's not going to have the same kind of impact. It's not going to have the same kind of meaning. And it's not going to do what it's intended to do. So if there's some way we could get to the basics with empathy, respect, as a starter, then I think we'd be all for the better in whatever discipline it might be.
Thank you for that, Dr. I know we're at 7:28. We're almost coming up on time. So before we shut down, a couple of things I want to point out. One, the presentations this evening and the resources. Dr. Hahn, Dr. Walton, and Dr. Johnson provided some resources that we didn't have a chance to share. But the presentations, the resources, the transcript from the chat will be provided to each of you who registered for this evening's presentation. And I want to tremendously thank each of our presenters, Dr. Hahn, Dr. Johnson, Dr. Salazar, and Dr. Walton for an excellent presentation and conversation. And we hope that each one of you, one of the underlying themes I heard this evening as we're dealing with diverse communities, both within healthcare settings and outside as we look at the community, how we within our own communities, whether it's African-American, Latino, Asian, or LGBTQ, how we can become more engaged and involved. And in that regard, the Alzheimer's Association does have a call to action for each one of you. We now have 2 FDA-approved treatments that change the course of Alzheimer's disease in a meaningful way for people in the early stages of the disease. And unfortunately, this decision by the Centers for Medicare and Medicaid Services, their current decision is denying coverage for FDA-approved Alzheimer's treatments. And frankly, that's unprecedented and unjust. Americans are living with Alzheimer's disease, and those who have HIV and AIDS and other medical conditions, they are entitled, they must get this kind of coverage. And so next Wednesday, matter of fact, May 24th from noon to 1 p.m., there's going to be a rally at the Department of Health and Human Services at their headquarters in DC. It's on 200 Independence Avenue. If you have time, if you have opportunity, if you want to get engaged in this regard, please join us. And you can register for the event at alz.org/NCA, National Capital Area. So please join us if possible. Clearly, together, we can raise our voices to demand that CMS change its decision so that people living with Alzheimer's can have more time to enjoy their lives. Also, if you have an opportunity, like Dr. Hahn, like myself, to become community educators or support group facilitators. And also 2 upcoming events. In June, we have what's called the Longest Day. It's usually the summer solstice. Communities throughout the Washington area, they may have fundraisers, they may have a community event. They're handing out information about Alzheimer's dementia, about resources, things of that nature. So if you have an opportunity, go to our website and look at the Longest Day. And then also the Walk to End Alzheimer's. That's usually in the fall. It's a way of, again, raising awareness, raising funds, making sure, again, communities of color, we need to be involved in clinical trials and clinical studies. We need to ensure that our voices are heard. And so we hope that you can join us in any of these various entities. And so I'm going to turn it over to Sheila and or Laura if there's any final closing remarks as we end this evening's presentation.
I think you said it well, Michael. It looks like Steve is sharing some of these slides, and this is exactly what Michael has just said. And again, you will receive these slides, but thank you. I wrote in the chat, thank you so much for everyone who has joined us tonight, the speakers. Great job, bravo, really wonderful. I learned so much from all of you. And Michael, thank you so much for your great moderating skills. You are just wonderful. So thank you all. And we hope to see you either at the rally or just in our website, getting some information about all of the things you've heard today. Thank you.
Thank you all and have a good evening.